Okay, so we're going to talk about the differential diagnosis of acute kidney injury, mainly in the intensive care unit, but it does overlap. Okay. Is it that one? I could just say next slide. Next slide, please. No, I'm not doing very well with technology. Right, it's a different one, okay. Right, these are my disclosures, none of which are actually relevant, apart from some of the biomarker stuff, but I won't tell you which one to buy. So this is a thank you to the SRLF for, again, inviting me to speak. So I'll start the lecture with some take-home messages, just in case the rest sends you to sleep. So remember, as a community, we invented acute kidney injury. Okay? Remember that. Remember that acute kidney injury is not a diagnosis. Remember that acute kidney injury must have a cause. And also remember, and this is important I think, that no acute kidney injury by KDIGO criteria does not mean no kidney damage. Okay? Right. This is Geppetto. He's praying that Pinocchio will turn into a little boy. And as intensive care doctors, this is what we do, right? We see a cluster of signs and symptoms and we pray that they will become a disease. So PRESS, ARDS are two examples. And this is the curse of intensive care, really. We observe a syndrome, and then we invent a disease, and then we spend all our time looking for a cure for the disease that we invented. So acute kidney injury, we observed the fact that creatinine goes up associated with different conditions. We called it acute kidney injury. Some people refer to it as a disease, and now we look for a cure for acute kidney injury. I can tell you there isn't a cure for acute kidney injury because we have to diagnose the cause. Now, acute kidney injury, of course, affects the ITU, but that's just a small percentage. There's a large amount on the wards. There certainly is in the UK. I'm sure there is in France as well. And there's a huge amount in the community. So we'll just really concentrate on the top bit, but the principles apply. Now, if we're trying to think of how we investigate acute kidney injury, we have to have some idea of the causes. So this is probably the most up-to-date epidemiological study, which was a prospective study, ACI published in ICM, and that looked at 97 different centres with patients from around the world. So you can see there are over 400 from the US, 700 from Europe, 34 from Africa, not too many from sub-Saharan Africa, but about 1,800 patients in total. What did that tell us? Well, these are the reasons for admission for this group, and there's no big surprise. Hypovolemic shock, septic shock, liver failure, acute abdomen, for example. And they were reasons for admission, and there was an association with the development of acute kidney injury, apart from in neurological cases. And if we look at the surgical causes for acute kidney injury, transplant, cardiac, but neurosurgery, curiously, seemed to have a protective effect against acute kidney injury. So we've never really been able to answer that. Interestingly, the other surgery, I work in a hepatobiliary and upper GI centre. We get a lot of acute kidney injury, so I'm surprised that that didn't come out in this study. These are the comorbidities associated with the development of acute kidney injury. Again, no fantastic surprises here. Diabetes, cirrhosis, hypertension, heart failure. But COPD isn't, as you may or may not be aware. These are the predisposing factors for acute kidney injury. Diuretics, 32%. Non-steroidals. It's interesting where we say no one uses non-steroidals in ITU. Well, 12% of cases were on non-steroidals. Aminoglycosides, glycopeptides. Amphotericin, which was a big villain when I was A trainee, not at all, and contrast wasn't deemed to be a particularly marked predisposing factor. And this was the etiology of acute kidney injury within this cohort. Sepsis, hypovolemia, drugs, shock, hepatorenal, and obstruction. So really, in most cases on the ITU, it's the usual suspects. Sepsis, hypovolemia, and any others, drugs, obstruction, HRS, and cardiogenic. And certainly hepatorenal syndrome has become more prevalent now than it was 5, even 10 years ago, or 10, even 5 years ago. So what diagnostic workup would I recommend to confirm the cause of your acute kidney injury? Well, the first thing is exclude the usual suspects. The ones we've just discussed, and hypovolemia and sepsis being the two most important in the ITU. And then you can perform some basic tests. So this comes from an excellent review that was just at the end of last year by my friends and colleagues, Molly Osterman and Michael Ioannidis, and it's in critical care. So I think you can get this off the website, and it's open access. So they suggest that if you have a patient with acute kidney injury, they should have a full blood count with differential, urine dipstick. I mean, urine dipstick never happens on my intensive care unit, despite the fact I shout and scream. Urine microscopy, I think that rarely happens. Renal ultrasound, probably as part of a bigger makeup. Serum calcium, always, and urinary electrolytes, rarely, I would say. So even though these are seen as the basic diagnostic workup, I'm not entirely sure that I would include the urinary electrolytes. As you can see, they've said they're optional. So we exclude the usual suspects, and if the cause remains unclear after the basic tests, then we could consider some further tests after that. So it's only really where you can't convince yourself it's one of the obvious things. And this is the slide I used to get people thinking about how you would look for a certain cause. So this is a question for the audience here. How many people can see one tiger? Okay, not many. How many people can see two tigers? All right. How many can see three tigers? All right. Well, the answer is there is not three tigers, okay? There are two. There's the tiger, and then there's the hidden tiger. If you look very closely, you can see within the stripes, it says the hidden tiger. So there's a tiger written on the tiger. So the idea is that sometimes we have to look for the hidden tiger within our patients. So there's one with the other one hiding in its stripes. So this is the next raft of tests that people may suggest. So if you have a glomerulonephritis or a vasculitis, these are all the things you could consider sending. Interstitial nephritis, interestingly, when I've done renal biopsies, that's the most common thing I find. Abdominal compartment syndrome, well, we may measure pressures as a routine. TTP, HUS, rhabdomyeloma, sepsis, cardiorenal. So, but all of these should have some features to make you suspect that that's what's going on. Don't just send every test, because then you'll end up like the Americans. Sorry, you'll end up bankrupt. So it really does depend on the clinical context and the clinical signs that are elicited. And this is the full workup here. You see the initial full blood count differential, etc. If the cause remains unclear, blah, 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 then you can move on to these. It's a lot of stuff to think about. But if you're sensible, you can be sensible with the use of your tests. Otherwise, it's going to cost you a lot of money. And not only is it going to cost a lot of money, most of the tests are useless. This is a really good paper that came out at the end of last year, where they looked at diagnostic testing in patients with acute kidney injury from the States, and they looked at a 12-month period. It was all AKI, not just ITU. Okay? So nearly 5,000 patients admitted with or developed acute kidney injury, and they had 5,700 AKI episodes, and most of it was stage 1. These are the tests they had. The clear box here is 1, 2, and the black ones are stage 3. So you can see urinary analysis was quite common. Urinary sediment was very common. This was an American paper, remember. Urinary sodium, creatinine, urea, eosinophils, total protein. And this is the biochemistry, or the plasma tests. So the anchor, so 2% of stage 1, and that was 71% of acute kidney injury. So that's 2% of 5,700, so it's quite a lot. But the stage 3 had more of the plasma tests. And then this actually looks at the tests, how many were abnormal, and how many actually affected management. Okay, because that's the thing we're really interested in, how many affected management. And you won't be surprised to know that this little black box here is actually the test results that affected management. And most of the tests were negative and of limited clinical utility. It's only when you look at radiology and pathology that there's more clinical input. You can see here stage 3 all had a renal ultrasound. Well, actually they didn't. A majority had a renal ultrasound, and some had a CT of the abdomen and chest. And again, in terms of affecting the outcome, much the same. And in fact, because the numbers are a bit lower in this group, you actually need to do 5 CT scans before you found something abnormal, 16 ultrasounds before you found something normal, and over 60 urinary eosinophil counts until you actually found any urinary eosinophils. So if you apply the test without thought or without looking at the clinical context, you'll waste a lot of money. And it doesn't actually matter who you ask. So the ITU doctors really couldn't tell much difference between them and the ED. Maybe the nephrologists just got a little bit better, but really not much at all. They were slightly more selective. But as I said, only 2% of tests affected management. So what about kidney biopsy, the gold standard for the nephrologist? Here we have a renal biopsy there. I'm not going to go into details about this. This was a nice editorial written by Mathieu Legrand, where they actually debated, is it worth the risk of biopsying people in the ITU? There were 2 studies which showed a complication rate of between 12.5% to 22%. Really, you would expect a complication rate from a percutaneous biopsy of less than 1%. Now, I published work using transjugular renal biopsies, but again, whether they really affect management in most cases is debatable. This is another paper. We actually looked at biopsy changes and tried to relate it to KDIGO definitions, and all that found is that most people who had a biopsy tend to have it late in a disease, and it wouldn't really have affected management. So some of you are probably sitting there saying, yeah, we know that, but what about biomarkers? And they're the new thing, so what do they tell us? Well, this is just a run of the current amount of biomarkers we have. Markers of GFR, which my colleague who was on before just told us about. Markers of inflammation and repair, proenkephalin being one the ED doctors love, and markers of tubular function over the other side, which are considerable. So the biomarkers tell us about glomerular function, inflammation and repair, and tubular function. But they don't really tell us much in terms of differential diagnosis. But what they can point to with changes of function, such as serum creatinine, is whether there's damage, and damage that you may not realize because the rise in creatinine has not been particularly high. So you may have a situation where you have loss of function without damage. You're not allowed to say pre-renal failure now, but in severe hypovolemia. But you may have damage without loss of function, where your creatinine appears normal or your urine output is maintained, but the biomarkers are positive. Now, is that a bad sign? Well, yes, it is. There is evidence now that suggests if you're biomarker positive, you've still got some renal damage, and you need probably quite severe, you need follow-up as any other patient would. This is how you may fit in tubular damage compared to glomerular damage. So if you're looking at glomerular function, your functional markers, that's creatinine urine output, for example, are decreased, whereas tubular injury may show your biomarkers showing some positivity. This is an important slide, not least because it comes from one of my papers, but it's just to highlight the fact that if you're young and fit, you have to lose a lot of GFR before your creatinine rises. And so, if you're elderly or if you have a GFR of 30, then a rise in creatinine to hit the AKI criteria doesn't require much fall in GFR, whereas if you have a GFR of 120, you've got to lose about 50% of your GFR before you get a creatinine rise. And that's something to do with something called the functional reserve, which I'll talk to you about later. So the next slide would have been the take-home messages, but fortunately I showed those at the beginning, so we don't need to do them again. So thank you very much for your attention.